I want to welcome you to the General Services Administration, or GSA. Great place to work. Thank you for joining us at our annual OES event. If you're not familiar with us, we're a team of interdisciplinary experts that work across government to help agencies build and use evidence. Team members work alongside agency collaborators to apply behavioral insights, make concrete recommendations on how to improve government, and evaluate effectiveness using administrative data. We're uniquely situated here at GSA at the center of government to share leading practices, develop resources, and build evidence and evaluation skills among them. That sounds interesting. Did not. We have some options for you to work with us, but I'll tell you a little bit more about that later. Kind of like a teaser. Each year we hold a similar gathering to this one to showcase the impressive work of our agency and our academic collaborators. We also disseminate the lessons that we've learned throughout the past year. This effort allows us to learn from each other, and it makes our evidence building activities more useful. The theme of this year's event is Using Evidence, Learning from Federal Evidence Building Activities. Over this past year, our team has completed 12 rapid cycle evaluations with 7 different agency partners. You have summaries of a lot of these projects in the folders that you have. Take time to look at those as you get a chance, but also visit our website, which is at oes.gsa.gov. And you can learn more about the project, not only we've done this year, but in the past, and learn more about our team. We hope today's presentations will provide you with practical examples of useful, low-cost federal evidence building activities, and that will help all of us generate new ideas for collaboration. At today's event, we're focusing on 3 key topics: learning from low-cost evaluations, learning from unexpected results, and learning from administrative data. We hope you enjoy the 3 sessions. We're joined today by our esteemed agency colleagues, our agency academic collaborators, and of course you, our wonderful community. We're truly grateful that you continue to be interested in our work and support us. Thank you in particular to our presenters, who came from across the country to share the important work we've been doing. We do welcome all of you to share about this event on social media. So if you can use the tag @USGSA and the hashtag OES@GSA. Great. Now I'm pleased to introduce GSA's Office of Government-Wide Policy Associate Administrator Jessica Selmerod. Jessica?
Thank you so much. I'm really excited to be here this morning, and I really appreciate the warm introduction. I am Jessica Salmaraki, GSA's Associate Administrator for the Office of Government-Wide Policy, which houses OES. If you're new to GSA, welcome, and if not, well, then welcome back. A little bit about OGP, where OES is housed. The office is here to help create a more effective, efficient, and responsive federal government for the American taxpayer. We have a focus on improving the environment to help agencies succeed in their mission, drafting regulations to guide the government in their purchasing, and by testing low-cost or no-cost changes to hopefully improve how the government works. That's what brings us here today. I'm excited to be here to highlight the work that OES and their collaborators have done to build useful evidence. OES's 2019 portfolio is an example of the effort needed to bring low-cost evaluation to bear on the challenges that federal agencies face. This is central to the mission of OGP, as we strive to be a collaborative and objective analytics partner across GSA and the federal government. We endeavor to help agencies achieve outcomes and create efficient and effective programs through collaborative efforts. As teams across the federal government work to implement the Foundations for Evidence-Based Policymaking Act of 2018, OES has been tasked with developing a system of evidence building. At GSA, we have recognized that data-driven decision-making allows us to learn what works to save the organization time, money, and resources. Implementing the Evidence Act is an opportunity to create a system that uses data to advance agency priorities and serves the American people. Here at GSA, OES has been leading the way in understanding what it might look like to meet the requirements of the Evidence Act in a way that is both meaningful and useful. The final point I'd like to make today is that OGP and GSA aim for transparency in our work. This event is about sharing what's been learned, both what has worked and what hasn't, and ensuring that those lessons are applied in future efforts. This is a commitment that OES has demonstrated in their studies, regardless of the outcome. We hope that today's event will help to drive application of lessons learned towards new efforts. And for that, I want to thank you all for being here. Now, I am pleased to introduce Diana Epstein of the Office of Management and Budget, who will provide some additional opening remarks.
Thanks so much, Jessica. My name is Diana Epstein. I lead the evidence team at the Office of Management and Budget. Among other things, OMB is responsible for supervising the administration of executive branch agencies, which includes issuing guidance to implement new laws, such as the recently enacted Foundations for Evidence-Based Policymaking Act. We affectionately call it the Evidence Act. So we think the Evidence Act provides a really unique opportunity for agencies to significantly rethink how they plan and organize evidence building, data management, and data access in order to better build and use evidence to support decision making. I'm very happy to be here today to recognize the OES team for the important work that you are doing, have done, and that you will continue to do to use evidence to tackle some really key challenges that are facing government. Not only does this support GSA's vision of an effective and efficient government for the American people, it also supports the President's management agenda, cross-agency priority goal related to fully leveraging the value of federal data for mission, service, and the public good. And it also supports the kind of evidence building activities that are a key focus of the Evidence Act. So today we're going to hear examples of how data and evidence have been applied to answer some of those critical questions. We'll hear about the diverse kinds of analyses that contribute to evidence building, how to effectively make use of administrative data, and how null or unexpected results can also make really important contributions to learning. OMB and GSA both take a really collaborative approach to our activities, and OES reflects this by collaborating across government to build and share evidence with federal agencies like Department of Health and Human Services, Department of Housing and Urban Development, Department of Defense, just to name a few. Through these collaborations, OES is able to provide low or no cost recommendations for improving how American citizens interact with their government. Results and outcomes that this impressive team has produced with the support of their important collaborators are really an excellent example of GSA's commitment to efficiency and effectiveness. So I thank you all for being here today to learn more about their work over the past year. And now I will pass it back to Mike to introduce the event's first panel.
Great. Thank you, Diana and Jessica. Great. Over the next couple of hours, we hope to provide you with some practical examples of useful evidence building. To start off with, we have a session on learning for low-cost evaluation, during which we'll hear about 4 collaborations between OES and our agency partners, in which behavioral insights have been applied to agency challenges and then tested through low-cost evaluations. To kick off the session, I'd like to welcome up Stephanie Garcia from the U.S. Department of Health and Human Services, Office of National Coordinator for Health and Team. Hassan Ahmed from Innova Health System, and our own Pankaj Roy from OES. Please hold your questions until after all of the sessions. We'll have some time at the very end at which you can ask anyone.
Good morning, everyone. I'm Stephanie Garcia from the Department of Health and Human Services, the Office of the National Coordinator for Health Information Technology, ONC for short. And we are charged with coordinating national efforts to implement and use the most advanced health information technology and support the exchange of electronic health information for the improvement of health outcomes and to support the research enterprise. We've identified increasing patient-generated health data, or PGHD, as an important opportunity to advance the engagement between patients and providers. Our work has included overseeing a project that was supported by the Patient-Centered Outcomes Research Trust Fund that identified best practices, gaps, and opportunities for progress in the collection and use of PhD for research and care delivery. So this project began in 2015 and closed out in 2017. And so far, some of the trends that we found in the adoption of PhD is that while the percentage of individuals that has access to their medical records did not change between 2017 and 2018, with 52% in 2017 and 51% in 2018. More than a quarter of health and wellness apps on electronic monitoring device users shared that information from those devices with a healthcare professional. Also, we found that about half of all smart tablet users and smartphone users have an health or wellness app on their devices to capture health-related or wellness-related information. This indicates that PhD is being shared with their health professionals, but also that there is an interest in collecting this information on behalf of the consumer or patient. So we were excited to partner with the Nova Health System and OES on a project promoting the uptake of PhD, and I will pass the microphone over to Hassan Ahmed at Nova Health Systems, who will now share more about this project.
Good morning, Hassan Ahmed from Innova Health System. I'm the Special Project Manager for Innova Medical Group's Centralized Analytics and Decision Support Team. One of my responsibilities includes supporting physicians through EHR optimization efforts, and that's what brought me to this particular project as a sub-investigator. At Innova Health System, our mission is to provide world-class healthcare to each person in every community we have the privilege to serve. One patient-generated health tool that we learned is underutilized is electronic blood glucose flow sheets. Self-monitoring blood glucose can improve the health of people with diabetes. And a 2017 CDC estimate indicates that there may be up to 100 million people in the United States with diabetes or pre-diabetes. We are excited to test this intervention because we often make updates to our EHR system Epic, but we've noticed that providers and patients don't always adopt them. And diabetes patients are frequent visitors to our health facilities. Innova sees 7,000 patients with diabetes each year, and typically these patients see their physicians 3 times a year, which is more than most patients. We really wanted to test patient engagement and see the impacts it could have on patient care. So we worked with OES and ONC to design an intervention to increase self-monitoring of blood glucose by encouraging providers to place bulk orders for electronic blood glucose flow sheets for patients with diabetes, and encouraging patients with diabetes to complete the flow sheets. We hope to do this by providing information to providers about the availability of the flow sheets, reducing barriers to patient use for their use by patients, and motivating patients to use the flow sheets through reminders. Now I'll pass it on to Pampa DeBroy from OES to discuss the study design.
Thank you, Hassan. So we conducted the randomization at the primary care level. Among 20 primary care practices, we randomly assigned half of the practices to an intervention group. 34 doctors with just over 3,400 patients were invited to attend a virtual training on ordering the flow sheets and offered in-person support. The other half were assigned to a control group for business as usual, and the flow sheets were available for physicians to order, but they received no systematic encouragement to do so. So on the patient side, we assigned about 2,200 patients in the intervention group to one of 4 messaging conditions around self-monitoring their glucose. So they received either no reminder, a basic reminder, a reminder with an opportunity to get a gift card, which was from, or a reminder sent from the patient's doctor reinforcing the importance of tracking this information. So the team used data that was available through the electronic health records to compare the 2 groups of practices and the reminder assignment patient groups within the treated practices. This existing administrative data was routinely collected and included provider flow sheet orders, patient flow sheet completion rates, A1C testing data, appointment data, prescription orders, and active medications before and after the intervention. Hassan will now discuss results.
So in testing this intervention, we found that patients at primary care practices that were randomly assigned to receive encouragement for bulk orders of the flow sheets were more likely to receive an order for the flow sheets, more likely to use the flow sheets, and less likely to see a change in their active medications in the 14 weeks following physician training. The training itself took just up to 10 minutes, and we were able to show that running the training helped us achieve our goal of getting more doctors to use the EHR features. Typically, this can be really hard to do. We also found that patients who were sent the reminder with information about the flow sheet's usefulness to their doctor were more likely to use the flow sheets, had fewer prescriptions overall, fewer diabetes-related prescriptions, and were less likely to receive an A1C test. This was useful for us to learn because we were able to send the messages in bulk. We don't actually need each individual provider to write them, but now we know what wording is most effective. Overall, patients that were prompted to use the electronic flow sheets experienced lower rates of office-based A1C testing and diabetes-related prescriptions with no evidence of adverse health impacts. This suggests that electronic blood glucose tracking could potentially act as a substitute for more costly testing and treatments. Physician access to consistent and reliable blood glucose data subsumes the need for a formal lab A1C test, which costs about $27 per outpatient test at Inova. The intervention resulted in an estimated 17% reduction in A1C tests among those that received the intervention as compared to those that did not. This has huge cost implications when translated to the estimated 30.3 million Americans living with diabetes. This project demonstrated to us that a small intervention can increase the usefulness of our EHR system using tools that are already available and provided evidence of effectiveness. We were able to obtain this information at low cost with minimal impact to the providers participating. From the initiation of the project to releasing our results, this effort was completed in approximately 2 years. Based on the results of the study, our recommended next steps are to make all providers aware of the functionality within the EHR to allow patients to enter their glucose results online, as well as create and send documentation with instructions on how to place those orders. We will also provide written patient instructions and a reminder message that the physicians can use to encourage use of the tools. We hope that utilizing this technology can continue to reduce costs and provide better care for our patients.
I just wanted to quickly note that ONC does continue to carry the torch for PhD. We've incorporated lessons learned and tips from the practical guide and the white paper into the Health IT playbook, which is periodically updated. It's a health IT resource or an electronic resource available for clinicians to support them in the adoption and use of health IT. And also on we see consumer empowerment as one of the ways to drive competition in healthcare and further drive down costs.
Thank you. So next up, we have Alana Safran from OES and Bob Weathers from the Social Security Administration Office of Retirement and Disability Policy to present on timely wage reporting among SSI recipients.
Morning. My name is Bob Weathers, and I'm a supervisory economist at the Social Security Administration. At SSA, we take the stewardship of our programs very seriously, and we're constantly looking to administer the old age survivors insurance program, disability insurance program, and the supplemental security. Supplemental security income, or SSI, is a monthly payment to people with limited income and resources who are disabled, blind, or ages 65 and older. It is intended to provide a cash supplement to those with limited income so that they can meet basic needs. The amount of the supplement depends on their income and resources. In order to ensure that SSI recipients are receiving the right amount of SSI, we require timely and accurate wage reports. Failure to report changes in wages accurately and promptly is a major source of improper payments to the agency. And according to our annual SSI stewardship review, included an estimated $3.4 billion in improper payments in fiscal year 2015. In that year, we sent specially designed notices to a random sample of SSI recipients to remind them of the wage reporting responsibilities. The design of the notice and the evaluation is a collaborative effort that I worked on with Rob Metcalf when he was a fellow in the Office of Evaluation Sciences, and now at Boston College. Judd Kessler from the University of Pennsylvania. Yue Zhang, who's now at University of Wisconsin, and Jeff Hunter at SSA. This collaboration started soon after OES was formed. Lana Saffron from OES will take over and talk about intervention testing.
Hi, I'm Alana Saffron. I'm a portfolio lead at OES, and I work on health imaging projects. So one important thing that Bob noted is that in addition to age, disability status, and residency, recipients' eligibility and monthly payment amount are determined based on their financial resources and their countable income. Each month, SSI recipients are required to report any changes in their resources and income to SSA. But in the course of usual events, they aren't given regular reminders for monthly reporting. So building on research that reminders can be motivating to individual behavior, our team tested 4 variations of a reminder letter to SSI recipients who had previously not reported any income. The first intervention was a basic reminder letter. The second was based on insights that people gravitate towards behaviors that they observe others take. And so our team tested a social information letter with information about others' behavior. The third, which was based on information that salience can increase the likelihood that people act on it. Our team tested a penalty salience letter with information about penalties for failure to report. And finally, our team tested a combination letter with both the social and the penalty information. So 50,000 SSI recipients were randomly assigned to receive either one of the 4 letters or a no letter control group. And data from Social Security's primary data on SSI, which is called the Supplemental Security Record, was used to track their subsequent reports of earnings and the dollar amount of those earnings reported. Our team found that 3 months after receiving the letters, 0.97% of SSI recipients in the control group reported earnings for the previous 3 months. But the reporting rate for SSI recipients who received any of the reminder letters was 35% higher, or 1.3% reported in total. And we also found that the amount of income reported by the treatment group was about 75% higher among the people who received the letter, which amounts to about $10.76 more each month.
Importantly, we found that the letters resulted in cost savings because each additional dollar accountable earned income increases the recipient's benefit by 50 cents. Based on the $10.76 increase in wages reported, a cost-benefit analysis suggests that the letters generate a reduction in overpayments of approximately $9.44 per dollar spent by SSA. Taking on this type of evidence building a project to meet a specific agency strategic goal, reducing improper payments, is new to SSA. And it really demonstrates the agency's commitment to being a good steward of program administrators. We plan to build on this experience in at least 2 ways. First, we think that we might be able to make further improvements to the notices by highlighting other important reporting responsibilities. Second, we think we might be able to improve the target efficiency of the notices using administrative data and results of our evaluation. Once we have made refinements to the notices, we'll develop a proposal to send the notices to the entire target population on a regular basis.
Next up, we welcome Lucas Tickner from the Veterans Benefits Administration and Dennis Kramer from OES, and they're going to be presenting on using proactive communication to increase college enrollment for post 9/11 GI Bill beneficiaries.
Great, thank you very much. Good morning, everybody. My name is Luke Tickner. I am from the Department of Veterans Affairs. At the VA, we really want veterans to choose VA when they are seeking clear information and making decisions about their well-being and independence throughout their life journey. In order to do this, the VA must earn veterans' trust through increased accountability, consistency, and transparency. Fiscal year 2019, the VA provided over $11 billion in GI Bill education benefits to beneficiaries who used the post 9/11 GI Bill. Now, the 2015 Veteran Economic Opportunity Report found that post 9/11 GI Bill recipients took longer to complete certificates by about 2.3 more years, associate's degrees by about 1.8 more years, and bachelor's degrees at around 2 more years when compared to traditional beginning post-secondary students in the general population cohort. We want to give veterans the education benefits they've earned, but they took longer to complete their degrees, and attending college part-time puts them at risk for not completing their degrees before exhausting their GI Bill benefits. Additionally, it's important to understand how the GI Bill benefit works, in particular the post 9/11 GI Bill benefit. This benefit is different than other education benefits in that doesn't have a time limit, doesn't have a limit on credits or dollars that we pay out. We actually have instead there's a time limit that can be used, the benefit can be used for a set number of months. Because this is different from most education benefits, it's likely to be misunderstood, resulting in veterans exhausting their education benefits before completing their degrees due to enrolling in fewer credits. And now Dennis is going to talk about our intervention.
Yeah, so thank you, Luke. Again, Dennis Kramer, Office of Evaluation Sciences. And when Luke and I got to talking about the challenges around the post-9/11 GI Bill, we really identified this information-based barrier that we could potentially address through proactive communications, or what we've learned from the team. And so we worked with Luke and his team at BBA, Education Services, to develop a proactive communication aimed at increasing enrollment for post-9/11 GI Bill beneficiaries. Particularly, we wanted to encourage full-time enrollment, but also provide information not only on other services that are available for financial aid, but also some potential benefits for completing your degree in a timely fashion. So the aim of this communication really was to incentivize or break down some information barriers so beneficiaries completed their bachelor's degree or degree before exhausting their benefits. And we included additional information on how they can access PA education services. So what we did is we capitalized on really robust administrative data and used a block randomization where we randomly assigned over 100,000 post-9/11 GI Bill beneficiaries to either receive a proactive email or not, right? So we're really interested in what was the effect of this proactive email. We took into consideration in our block the type of beneficiary you were you a veteran or a dependent, how much benefit balance you had. So as we talked about, it's a month-based benefit, not credit-based on what was the level of benefit you had remaining, and the type of the institution that you actually attended, because we know that there's differences between those attending community college versus a four-year institution. What was nice is that the VBA automatically collects or already collects information on post-secondary enrollment intensity from all those beneficiaries who are accessing the benefits. So we capitalized on that, and we looked at the comparison between the enrollment and kind of the immediate fall term after we sent out the information. And data included information on college enrollment and the intensity, as well as the benefits they were getting. So, all right. So what did we find? So we had two primary outcomes. The outcome you see up here is the overall rate of pursuit, so their enrollment intensity, but we also looked at the proportion of beneficiaries that were enrolling full-time. For those that were enrolling full-time, those in the control group enrolled at a 36.8% rate, whereas those that were in the control group enrolled at 36.5%. So a slight increase in full-time enrollment, which was not so significant. However, we did find that the rate of pursuit on average for those receiving the proactive communication was 1% higher in our treatment group than those in the control group. So you can see here, those that received a proactive email had a rate of pursuit of about 75.3% compared to our control group at 74.6%. Because we sent this email out through Gov Delivery, we were able actually to look at those who accessed and opened the email. And so when we looked at those who actually opened the email, the effect was even larger. So those that were assigned to the proactive email condition and opened the email had an enrollment or 3% higher enrollment intensity, or they had a 76.6% enrollment rate.
So in addition to learning that a low-cost intervention like this can result in positive impact for our beneficiaries. This process took less than a year from the time we started talking about it until we actually had results in our hand that we can deal with. And that was, it helps us as we look to say how are we going to make future adjustments to these types of interventions as we move forward. While we're still working through how we're going to directly apply the results of this particular evaluation, through the process of working with our OES partners, we've identified additional ways that we can use our data and leverage the proactive communications like we did in this case to have an immediate positive impact on veterans and beneficiaries in their educational pursuits.
So, thanks so much. Next up, I welcome Papa LeBroy from OES back up, and Dr. Vince Marconi from the Atlanta VA Health System to present on increasing vaccine uptake among veterans at the Atlanta VA Health System.
Good morning, everyone. My name is Vince Marconi. I'm the director of the Infectious Disease Research Program at the Atlanta VA, also professor of infectious diseases at Emory University School of Medicine and Global Health for Emory Law School of Public Health. And we strive to honor veterans in our system by providing exceptional health care to improve the health and well-being for over 9 million veterans across the country at VA health centers. And through this, we emphasize both prevention and population health to ensure all receive appropriate vaccines. Despite these efforts, many of our veterans remain unvaccinated. So our team saw an opportunity to improve vaccination rates by leveraging insights from behavioral sciences. So we sought a collaboration with the Office of Evaluation Sciences, both develop and test a low-cost and scalable intervention could improve uptake of vaccines for our veterans at the Atlanta VA. So in a true transdisciplinary approach, we sought first to work with stakeholders at the Atlanta VA, including individuals who worked at the Health Promotion and Disease Prevention team, the external peer review team, as well as administrative and primary care leadership. We also work with quality improvement teams and with direct providers themselves, including doctors and nurses. In our findings through this exploration, we identified that some providers are spending, on average, estimated over an hour of their day working on clinical reminders, alerts, and pop-ups in their electronic health record system. And because of this, it results in frustrations, what we call reminder fatigue or pop-up fatigue. And it also gets in the way of individuals being able to get patient-directed education at the visit itself, and even obviates key steps in the healthcare management of patients. We also have noted that many patients are still refusing vaccines despite the reminders happening. And finally, there's difficulty for the providers to view the vaccine history in a very easy way. So I'm going to turn this over to Papa to describe the study design results.
Thanks very much. So based on these bottlenecks that we observed, the OES and Atlanta teams worked together to design an intervention to increase vaccination rates. And really, we wanted to make the EHR reminders easy to use and intuitive. And we did this through the EHR, the electronic health record. So what we ended up doing is we decided to bundle together multiple vaccines. So right now, as Vince was saying, providers field several different reminders for each vaccine. And so we bundled together 3 important adult immunization reminders, so for Tdap, pneumococcal, and influenza, into one clinical reminder to address the number of reminders clinicians are required to field. We also created a dashboard relaying patient vaccination status to make viewing immunization recommendations as well as their history faster and easier. And finally, we included talking points for providers to use in their dialogues with patients based on evidence around what makes responses to refusals more consistent and effective. We then tested the set of interventions using a cluster-level randomized control trial. So we randomly assigned 84 clusters of primary care teams, which included physicians, advanced practice providers, as well as nurses, who treated approximately 24,000 patients to either receive the treatment, which is this modified reminder, or the status quo of the existing EHR reminders, which did not include the vaccination bundling, the dashboard, and the talking points. And we could then obtain data through the EHR to compare the treatment and control groups on receipt of vaccines. So this was our findings. We found that flu vaccination at the first appointment when due for the flu vaccine was higher among patients who saw primary care teams that were assigned the treatment than patients who saw teams in the control group, so 24.3% versus 21.9%. However, when accounting for demographic characteristics and the clustering of patients within respective care teams, we observed a statistically insignificant difference of 2.2 percentage points between the treatment and control groups for flu vaccination. But I will note that the original study design was powered to detect differences of 5.5 percentage points or more, and we are currently conducting additional analyses, which will include results of vaccinations for any of the 3 vaccines that were due, as well as at the patient level across all appointments.
Thanks, Papa. So as you can see, over the past year, this project has demonstrated the ability of our team working with OES to execute and test a change in the electronic health record system with an intervention that's focused on improving vaccine uptake within the VA system. This project does build on the OES portfolio of evidence to learn what works to improve vaccine uptake. And future work, we believe, is going to build upon these findings and test promising interventions in the future. And I can say in light of these results and its low cost, there's a clear indication from the administration that they want to take these efforts forward and more testing to be done over the ensuing years. So next steps for us are to try and modify some of the intervention. We can talk about the details of that later, as well as to roll this out on a larger scale and meet the powering that we're hoping for. Other interventions that we're planning in the meantime is to do report cards directed towards providers to sort of build some competition between the PAC teams, as well as doing some patient-directed outreach as well. Thank you.
Thank you. So I'll transition over to Mike to transition us to our next